You're listening to Addiction Medicine Beyond the Abstract, the official podcast of the Journal of Addiction Medicine. If this is your first time listening, thanks for coming. Addiction Medicine Beyond the Abstract is produced for your enjoyment and is focused on the latest journal-published research and science in the field of addiction medicine. Remember to add us to your favorites in iTunes. You can also follow us on Twitter at ASAMorg and Facebook. Now, let's go beyond the abstract.
Welcome to Addiction Medicine Beyond the Abstract. I'm your host, Dr. Sean McNeil, Digital Content Editor for the Journal of Addiction Medicine. Today we are joined by Dr. Gerald Cochran, an Associate Professor of Social Work and Psychiatry at the University of Pittsburgh and Associate Dean for Research at the University of Pittsburgh School of Social Work. His work focuses on substance use disorder interventions in the healthcare setting, primarily involving opioids. Thank you for joining us today, Dr. Cochran. I want to start by asking you to introduce yourself a little bit and also to discuss how you got into the field of addiction treatment and research.
Yeah, so the field of addiction medicine, it's a huge need, especially in healthcare settings. It's clear that individuals that come in with, different health conditions, in different kind of touch points throughout the system, oftentimes the comorbid conditions that make all of their other kind of health problems even worse are substance use disorders and behavioral health conditions. So from the social work perspective, and I am a social worker by training, this is where we feel like we can make the biggest change for individuals, addressing health behavior as well as social determinants of health. So that is how I came into this. And before being an academic researcher, I did a little bit of a combination. I was a health policy analyst during the day, and at nighttime I was an emergency department social worker in a Trauma 1 center. So I kind of got to actually help people at night and write about it during the day. And with mothers and opioids, we here at the University of Pittsburgh, when I first arrived, there was a group of investigators who got together and began talking about the kind of the opioid crisis going on, and how our women's hospital had seen huge increases in this area. And so there was a number of projects identified, and there was a pharmacokinetics project identified, there was kind of a translation project identified, and then there was a kind of a psychosocial during pregnancy project identified, and I, given my expertise in clinical studies and human-facing interventions or patient-facing interventions, and particularly with the patient navigation model, I led the project. So that's how I got into this particular area.
And I can see how that would lead you to the study that is coming out here in the journal.
Yeah.
I'd like to ask you if you could next give us a brief overview of the study, of the rationale and the findings.
Yeah, so the study provides, it's a pilot study that provides a patient navigation intervention to opioid-dependent women who are initiating buprenorphine at a clinic here in our women's hospital that provided buprenorphine care, prenatal care, and a little bit of case management services. To those services, we added on patient navigation, given that it's clear that the women, in addition to the needs that were being met at the clinic, had several other needs, psychosocial, housing, a lot of different kinds of needs, and they had, in engaging in those services and all the care services at the hospital, there wasn't kind of that individual who could help guide them through kind of getting engaged in those services and staying engaged in those services. And if you're familiar with the patient navigation model that's been very popular in oncology, particularly breast cancer research in the last 25 to 30 years. This is a patient-centered approach for chronic health conditions, for really helping individuals figure out how to navigate the health system in order to get the care that they need and stay engaged in care. So we felt like it was a really good fit for the population. Wanted to see if it would work in this particular care setting, and so we did a small trial where we recruited and gave women the opportunity to have 21 women the opportunity to have this patient navigation intervention, which was 10 sessions before delivery, and then 4 sessions after giving birth for that month, and really focusing on those key remaining adherent to their buprenorphine, getting engaged in behavioral health services, improving their quality of life, and so forth. So anyways, that's just kind of the overview of it.
The paper mentions that this is the first known time that patient navigation techniques have been used for. Is it for opiate use disorders, or is it specifically for expectant mothers with these disorders?
Yeah, so at the time, I haven't looked in the last, 6 or 8 months. Somebody else might have, scooped us. I don't think they have. Yeah, but specifically, patient navigation has been applied generally to some behavioral health, some substance use stuff, but not specifically to opioids from what we could find in the literature, and definitely not for opioid-dependent pregnant women, again, from what we could find. So we do believe it's a novel application of a fairly well-known evidence-based practice for this kind of new population.
Okay. Was there a certain process when adapting these techniques to the specific population?
Yeah, so that's a great question. So the navigation model was designed by investigators from the NIDA Clinical Trials Network a few years ago for a study they did with people who use alcohol and drugs who also have HIV that's not managed very well. So it was developed based on their model, and that model was essentially 2 different modalities: strengths-based case management plus motivational interviewing techniques. So from there, our team, we took that model, and you can read the main outcomes for that paper in JAMA. It came out like a year and a half or 2 ago for the NIDA Clinical Trials HIV study. So we took that model, and with the group from the NIDA Clinical Trials Network and other investigators from the University of Pittsburgh, we modified it, and it was simply an iterative process where we would make changes to the model to fit women, especially women in different milestones of their pregnancy, in order to kind of help them out at specific times during the course of treatment. And once we finalized it, we started implementing it, and we didn't make a lot of changes to it. The only major change that we did was in how we communicated with the women in some instances. The original model was designed to be delivered 100% in person, whereas at a clinic setting, whereas we met patients where they were at a lot of times because of whatever issues, and they didn't feel well or whatever it might be to get into the clinic. The other thing that we did a lot of that a lot of people I think are seeing in substance abuse studies is we communicated with our patients a lot via text message. And we didn't capture any of that, but if we were to take this study to the next level, there would be some really interesting potential applications of text messaging for engaging with the women and kind of keeping them engaged with the study as well as engaged in their own care. So again, we didn't capture any of that, but we actually had to kind of go by cell phones for our staff and everything in order just to keep up with the population, because it's a much more popular way to communicate these days. So anyway.
And you had favorable outcomes using these methods?
Oh, yeah. So I'll just say, if we hadn't kind of met the women where they were at in many terms, we wouldn't have been able to continue kind of keeping them engaged in many ways, because it would just be too hard, because, because just the course of pregnancy isn't, necessarily the most comfortable and easy kind of time in a woman's, health. So that's one. And the other is just, for a variety of reasons, the text messaging worked, in terms of keeping the women engaged and setting up appointments and sending, whatever information they needed for different aspects. That was really, really helpful. So, and you can tell it's reflected in, our retention rate. You can see in the flow chart of the study that, except for the couple of, so we had one woman who discontinued, but all the other women, and then we had one woman discontinue, and I believe it was 2 who had miscarriages that were no longer eligible. But all the other women, they all started and they all finished the intervention. So that was really awesome for us, and we were able to kind of watch them throughout and after. So
now, looking back on the study, how applicable are these results in clinical practice, and what do you see as the role of a study like this in shaping the future of treatment for these women?
Yeah, so how it impacts clinical practice, I think the most important kind of underscoring message is that, this is a potentially viable model, potentially, right, because it was a pilot study for the population, and it really shows that if, because we had kind of the natural comparison group, between the women who were discharged early versus the women who continued at the clinic, that if you can have someone like a patient navigator type individual continue to kind of engage and reach out to these women, you can really do a lot to make sure that they stay not only engaged in their prenatal care, but stay engaged in their MAT during the course of their pregnancy. So I think that's a really important thing. As different care settings set up, these kind of patient-centered models where kind of a one-stop shop. If a woman isn't compliant, with some sort of aspect, or she doesn't like that, and for some reason she stops going to that care setting, and she needs to continue on, with prenatal care, MAT. Having somebody who can kind of transcend organizations is really, really valuable. Not only for the woman and the neonate, but for public health generally, to make sure that there's good birth outcomes, that there's compliance with treatment, and there isn't some sort of negative ramifications. If there could be a coordination between multiple women's hospitals, or even multiple, in our case it was a women's hospital, but maybe outpatient ours is a outpatient clinic within a hospital, but multiple care settings for women who are dependent on opioids, who are pregnant. If there can be an alignment between organizations for a multi-center study, that would be a way to be able to really get a large sample of these women and test out the intervention on a larger scale. So I think it's a wonderful opportunity. I know we'd be very happy to at UPMC here to partner with other people in a study like that. So.
And I think you're going to have a lot of metrics or data on how are the women performing, and then how are the neonates performing.
That is the big hole that we did not, we mentioned in the papers, what's the story for the babies, and we are going to collect information on that. So hopefully with the 3 projects that we've done over the last few years here, we'll put something larger together, kind of more of a almost like like a program or like a center type project where we can actually kind of take care of the women from everything from how their medication is used to all the way to how their babies do, a year after they're born. So we're really looking at the big picture for the population.
Well, I want to thank you so much, Dr. Cochran, for joining us today on the podcast and sharing all this information with us about your study that's coming out in the next issue of the journal.
Yeah, thank you. It's been great to participate.
This ends today's podcast. Thank you for listening to Addiction Medicine Beyond the Abstract. All of today's show links can be found in the show notes. Remember, you can preview additional abstracts at journalofaddictionmedicine.com. This program was produced by the American Society of Addiction Medicine.